I grew up in southeast Los Angeles, close to South Central. You've heard about South Central? I lived in a lousy neighborhood. I was a C student in high school, and the only way I got to college was as a Division I football player at the University of Iowa.
Go Hawks!
Go Hawkeyes, yeah, thank you very much. However, what you said not only resonated with me, but there's a flip side to it. I was told, my dream was crushed in high school. My counselor said, you're never going to make it to college. You don't have the intelligence, you don't have the drive, you don't have the capacity to do it. Therefore, your only chance is sports. So I left California, first time I ever went to the Midwest. If you've never played football in cold weather, it's a real experience. If you grew up in California, the ball gets hard, the ground gets harder. You know, wild thing. But the thing that happened to me, which is why I was resonating with you in so many places, is when you first go to check in as an athlete, you go in early, they have a lecture that they sort of tell you the rules, and the rules are you have to have a passing grade point average, you don't play. Now, a passing grade point average is a mythical creature that's sort of defined by criteria that doesn't apply to every other student. You know what I mean? It's just basically show up and they'll take care of the grades. But I didn't know that, so I actually started to study. And I got a 3.75 my first semester. I thought, wow, now I have a PhD, I'm an endowed professor in the university. So they tried to crush my dream, but it didn't work. I quit playing football because they did crush my dream. They said, you're not good enough to go pro, which is sort of what they do. At a certain point, they say, guess what? You know, you're a good player, we recruited you, but you're not pro material. So I thought, I'm getting the hell beat out of me every week. Why am I doing this? So I decided to quit. The day you quit, your scholarship, whatever they want to call it, disappears. It is immediately gone. I mean, boom. And I had to transfer back to California. But anyway, I just wanted to share that with you because I was laughing internally, externally, anyway. What I wanted to talk to you about is translation research. That's what I do for a living here on this campus. And what that is, simply put, is I take the results of clinical trials, you know, basic research, if you will, and try to put it to the public health. My area of interest is diabetes. Now, why am I interested in diabetes? A lot of reasons, but predominantly because it's probably the major public health crisis of our time, and particularly in this country. We have 28 million people that have known diabetes and another 79 million that are at high risk for it. That's 1/3 of the country. That is over 50% of people who are adults. It's over 50% of people above the age of 65. It cost this country last year $245 billion in both direct and indirect costs of diabetes. That's billion. That's serious money. And it's now estimated that if we don't do something about this, what's going to happen is 1 person in 3 will have diabetes by 2050. Okay? So if you think we're economically in deep, guano now, just wait. Okay? Just wait. Imagine a country where 50% of the adults have diabetes, which is disproportionately expensive. It's the leading cause of blindness, lower extremity amputations, kidney failure. I can go on and on. Okay? Really expensive, costly disease. So, how to get into translation? About 15 years ago, Indiana University got involved with a study called the Diabetes Prevention Program. This was a study hosted by the NIH to look at could we prevent the onset of type 2 diabetes in people with what we now call prediabetes, or impaired glucose tolerance. And the short answer to that question is yes, we can. Not only can we do it, we can knock that risk by as much as 60 to 70%. But it requires getting people to adopt lifestyle change. The most potent thing that works is not medication. There are some medications that will do it. They're only half as effective as getting people to change their lifestyle. When I say change your lifestyle, I'm talking about losing 5% of your baseline body weight, which for most people, it qualifies 12, 15, maybe 17 pounds, right? And increasing physical activity to about 150 minutes a week of exercise. Well, this seems pretty simple. How many of you know where there's a diabetes prevention program around your community? Show of hands. Ooh, here's the problem. The problem is, even though we've known for a good 15 years that we could do this, we haven't figured out how to put that into the public health. Because when we did the study here, and we were one of 27 centers in Indiana, it's what we call an efficacy trial. In other words, we didn't care how much it cost. We just cared about proving the point. So I had an infinite budget for the 192 people that participated here on this campus. I had an infinite budget to get them to goal. If I wanted to send them to health clubs, I could pay for it. If I gave every person in my group Nike tennis shoes, okay, nice ones, right? I could do anything I could think of to get them to goal. Each person was trained in a lifestyle curriculum by their own personal coach. And it was done one-on-one. So you had an individual coach working with you, and you had one working with you, and so on and so forth. Great model. Who wouldn't like their own personal trainer, to get them through a lifestyle change? But it's not a good public health model. So we were sitting around one day over in my office, which is over at the Pitts building, and trying to think, what are we going to do about this? And we went to a meeting that was organized by the Marion County Public Health Department to sort of talk about what do we do, what's our health interest. In that meeting, I talked about the DPP, the Diabetes Prevention Program, and my work in that. After a break period was over, a person from the YMCA came up and said, we could do that. We could implement lifestyle change programs at the Y. And I went, interesting idea, why not? Nobody believed at that time that lay people, non-healthcare professionals, who I was using in my study, could actually implement a program like this. And so we thought, well, let's test it. So we set up a randomized control trial, because that's the hallmark of science here, right? And we did a study, and we proved that yes, the YMCA could deliver very effective diabetes prevention programming. And they could do it at the same level, the same performance level as we were doing with a $195 million study that the NIH was hosting. This set off a cascade of stuff, and so just with my last 10 minutes here, I'll tell you what sort of happened from that. So with great pride, I tell you that Indiana University is the epicenter of diabetes prevention research in this country. We brought the Y online. We figured out how to do that, and to do it at a cost point which was about a fifth of what it cost any other method to do it. We did it for a very reasonable economic dollar. For a year's worth of Y, I could do it for $200 a person, which is very cost effective, okay? So then the Y sort of said, interesting thing, Dave, could you help us bring it online and make it part of a national program? We said, sure, we could do that. So I started traveling around the country teaching people at Ys how to implement this program. I became like a traveling sideshow. I'd go to just one state after another and get them up to speed and get their programs going. Finally, the Y woke up and said, okay, why don't you teach a bunch of people so they can teach other people how to do this, train the trainer model. We developed that. The Y now has made it their national program. It's now being it's put into 24 states now. 600 or 700 Ys are bringing it online, and they're going to go across the country with this, bringing all 2,700 of their facilities up to speed. That's translational research. That's taking a simple idea from a clinical trial that was done with great precision and high levels of control and putting it into a real public health frame so people could actually access it and use it. But we didn't stop there. It was a great day at the office, as we say, to get the Y up to speed. Really good day at the office. However, it doesn't solve a fundamental problem, and that is it still isn't free. You can't deliver lifestyle modification programs, even at the Y, which is a not-for-profit entity. It only operates to recover costs. But they have to recover costs. You still have to charge. Unfortunately, diabetes is disproportionately represented in low-income populations and minority populations. So it's sort of a problem as a public health guy to say, well, how do we do this? How do we get it so people can afford it? Because $200 a year for some people, it's a decision. It's not just I got this. It's like I have to make decisions about this or something else, like their kids, So we started thinking about that, and the question is, how do we get third-party coverage? How do we get insurance companies to pick up the benefit? So a second thing happened in the wonderful world of translation research. The NIH asked Indiana University to host a conference to say, what data would third-party payment entities need to promote diabetes prevention? So we did. We hosted the conference. In fact, it was held the floor below here in this building. And we had all the usual suspects. CMS was there, the folks to bring in Medicaid and Medicare. The Indian Health Service, because Native Americans have the highest rate of diabetes in the world. The NIH was there, the CDC was there, on and on. And a bunch of third-party payers. United Health Group was there. United Health Group is the largest third-party payer in this country. They cover 60 or 70 million lives, so it's a big company. During that meeting, we had what we call the aha moment. It's a great thing when you get these. The person that was representing UHG, United Health Group, said, we can do this. We have the data on a huge group of the population, we can figure out who has prediabetes, and we can refer them to YMCA's. We said, yeah, good idea, let's try it. So we did, got a demonstration project. We did it in 11 states with 10,000 subjects. Guess what? UHG found out it's a cost-effective model to do this. So they started picking up coverage. So the big goal for me is always to get payment, to get somebody to cover the cost. So we did that, great day at the office, but we weren't done because we still have a problem. I got 79 million people and growing with prediabetes. We're at high risk. 11 to 15% a year are going to convert to diabetes. It's going to wipe us out economically, socially, and spiritually. How do I get more and more coverage? Because, even if I had everyone in the country doing this full time, that's only 2,700 entities and 79 million people. Do the math. It doesn't come out real well. So we started thinking, how can we expand coverage? So what do you guys think I did? Where do you think I went? Can I ask you? Anybody? Great idea. The problem with public schools and with children is you can teach kids all kinds of stuff. Then they go home and mom and dad feed some crap anyway. You know what I mean? It's sort of a bad model, particularly when you think about lower income and disadvantaged populations. And so when we did programs in schools, they worked fabulous. The kids get it. They come home and say, Mommy, I shouldn't eat this stuff. Mom says, shut up, and gives them the mac and cheese and the chicken, and that's how it goes down, right? So that didn't work. What I decided to do, what I'm doing right now, just finished a study, will be published very soon, is I went to the commercial side of things and said, who's out there doing weight loss? What's the big dog in weight loss in the commercial world? Anybody want to guess what it is?
Weight Watchers.
Weight Watchers. You are right. Weight Watchers has 25,000 coaches who are highly trained out there as we speak doing weight loss. 25,000. We're not talking 2,500 like the Y. We're talking 25,000. They have them on in this campus alone. There are 7 Weight Watcher programs. On this campus, there's 113 in the city. There are 13 YMCA's in Indianapolis. Okay, so the scale is remarkably large. Weight Watchers came to me and said, Dave, we'd like to get in on this third-party coverage deal. We'd like to have people pay for the benefit of going to Weight Watchers. Can you help us do this? I'm a translation researcher. You always say yes. I said, sure, I can do that. So what did we do? We set up a randomized controlled trial. We put people into a Weight Watchers program, which we did some tinkering with to make it specific to people with prediabetes and to do some education about prediabetes, and we ran the study. The study's still going on. It's a 2-year study, but we just finished the 1-year data term, right? And at 1 year, not only do people Weight Watchers lose the weight, they keep it off. And there's several reasons why Weight Watchers is an effective program. It works, right? You just have to structure it the way that makes sense for the payment structure. Well, we've now shown that. So Weight Watchers is getting ready to roll out a pre-diabetes primary prevention initiative that's going to go nationwide, and then they're going to go international, because Weight Watchers exists in 109 countries, right? But they're going to go international countries. So we're going to go from 700-800 programs that are available in the country today to 25,000 in about 6 months. Now that is public health. That's starting to get at the level we need, but we're not done. So next time I come here, I'll talk to you about where I'm going next, because I'm not finished yet. We have an enormous problem here. This is an enormous problem. We're talking 1/3 of the country, right? This is huge numbers. We're talking about people getting hammered and crushed, their spirits broken, and their bodies, slammed. We can't live with this. This can't happen in our watch. And it's not going to happen here in Indiana. We're going to deal with that. That's what I do for a living. Thanks for giving me the chance to tell you about it.